respected Independence Awardee, mother of pediatric cardiology, and pioneer in the field of interventional pediatric cardiology, Bangladesh, legendary Professor Brigadier General Nunnar Fatima, Head of Pediatric and Pediatric Cardiology, CMH Dhaka, Chief of Pediatric Cardiology, Labid Hospital, Dhaka, and Chairman of Congenital Heart Disease Foundation, Bangladesh. Respected Senior Consultant Pediatric Cardiology, Square Hospital, Bangladesh Limited, Professor ABM Abdul Salam, respected distinguished doctors and participants in home and abroad. Assalamu alaikum, Eid Mubarak, and very good afternoon to you all. Myself, Lieutenant Colonel Jannatul Firdaus, welcome you all to the series of weekend virtual cardiac class organized by Congenital Heart Disease Foundation on joint collaboration with Narayana Health and Beximco Pharma Limited. It is a great pleasure for me to give this opportunity to be a moderator of this weekend class. Heartfelt thanks to Madam. As a continuation of series of classes, our today's topic of discussion is critical care management in pediatric cardiac ICU, pediatric surgical ICU. Our today's speaker is Dr. Riyan Shetty, Consultant Pediatric Cardiac ITU, Head of Extracorporeal Life Support, Narayana Institute of Cardiac Sciences, Narayana Health City, Bangalore, India. Dr. Riyan Shetty did his MBBS from Father Muller's Medical College and his MD from Unipua Medical College in Bangalore. He did his cardiac anesthesia training in Narayana Institute of Cardiac Sciences, Bangalore, and cardiac intensive care and transesophageal training in St. George's Hospital, London. He worked as a fellow in pediatric cardiac intensive care and Ecmo in Royal Brompton Hospital and Great Ormond Street Hospital for Children in London. Dr. Riyan Shetty was a locum consultant in pediatric cardiac anesthesia in Greenfield Hospital, UK. Dr. Riyan Shetty achieved 10th rank in MD in 2009 from Rajiv Gandhi University of Health Science and President's Citizen Award in 2019. He has many publications in national and international journals. Now, I humbly request respected speaker to deliver his speech. Hello, sir. Am I audible, sir?
Yes, yes, yes.
Oh, hello, Jannat. I have joined. So,
okay, madam.
Okay, you start now. And welcome to Dr. Riyan Shetty. So please start.
May I repeat, madam, everything?
No.
Okay.
Hello, good evening, everybody. Eid Mubarak. And thank you very much, Professor Fatima, Dr. Jannat, and everybody present in this webinar. Greetings from Narayana Institute of Cardiac Sciences and Dr. Devi Shetty and from Narayana Health, Bangalore. I know it's a very difficult times we're going through. It's a good time to sit and go back to our basics. Thank you for giving me an opportunity to interact with your juniors in Bangladesh. As you know, I come from the Bangalore unit. We have almost 80 beds. We on a year where there's no COVID, we operate on almost 2,600 children. Almost 25% of them are from Bangladesh. So I'm learning some Bangladesh also, Bangladeshi Bengali language. I started counseling a little bit also. Thank you to the Bengali patients. Today I'm going to stick to pediatric cardiac intensive care because that's my strong point. I was told they also wanted something in pediatric surgical. I just didn't want to mix up the topics for the cardiologists. So I'm going to continue with pediatric cardiac intensive care. I would like to start off by saying that I would concentrate a lot in the first 5 minutes on the transfer from OR to ICU and the structured handover, which is followed all over the world now. It's called a Formula One Ferrari type of handover. Then I'll mix and match and tell you about some immediate postoperative care, some early problems, some late problems. And if I have time, I'll try and tell you something about some common surgical procedures. My talk will be almost 45 minutes. I'll try to finish it well in time. I don't know how many of you have seen this picture on the left side. It's a red color car. It's a Ferrari model. This is when they come to the pit stop to change their tires. There is, as you can see in the right, there's designated people to lift the car up, put the wheel, remove the wheel, put the wheel, even a person clean the visor and refuel, and also get spare tires. So you can see how many people are involved. So a long time back, when the Ferrari team went to the Great Ormond Street Hospital about almost a decade back and studied their handover process from the OR to the intensive care, they realized that the handover was very, very non-structured. Different people came at different times. People interrupted in discussions. The handover had to be repeated again and again, and all the handover was not documented well. They came up and told the doctors that I do not know how we have such low mortality, because this is one of the most critical times in the life of a congenital heart disease patient, that shifting from an OR to ICU, and important information, if they are missed, will really cost a life. And then they sat down with the ICU and the OR team and put in some protocols. And as of now, the what we follow is when the patient comes and docks, it's just like a pit stop. The consultant anesthetist and the registrar make sure that the ventilator is switched on, and the anesthesia technician, which is called the ODA in the UK, make sure the monitors are fixed. One of the nurses take care of the drain. Another nurse in charge takes care of the pumps, make sure it's connected to the power. And the nurse looking after gets ready to position the patient in the right place and gets ready to for the handover. There are 4 phases in the handover: a structured ICU handover from OR to ICU. One is the pre-handover, where Phase 2 is the equipment and technology handover by the consultant anesthetist. Handover information given by the anesthetist and the surgeon. And the Phase 4, when everybody groups together, chats, assess the patient, notes down everything, and then come up with a plan. So don't forget, Phase 1 is nothing but a pre-handover, where you inform the ICU that 30 minutes before arrival, either send the file or give them a phone call that the patient is coming within 30 minutes, so that they are ready with their ventilators checked, their monitors are checked, all the alarm limits are all set, so that the patient can come, baby can come and straight away dock in the ICU floor. The next is in the Phase 2, the anesthetist will supervise the transfer, as I mentioned. Handover starts only after the patient is stable. First the anesthetist, then the surgeon, and the intensivist and the nurse looking after should be present. There should not be any interruption. And then it's followed by an assessment by the fellow. He does a general physical examination. And then there's a combined plan by the headed by the intensivist, by taking the surgeon, the anesthetist, and the perfusionist into confidence. So first and foremost, if you look at the top of the screen, that's the assessment. And then you come to the examination, and then you write down. This is a structured form, front and back. It has it's like a checklist, so that none of the information is missed. The anesthetist, when he's handing over, goes through this checklist one by one and makes sure the intensive care fills it up. Once you come down to the plan, there are limits, there are prescriptions and drain or X-ray, whatever. There's a huge checklist, so that none of even a junior most person does not forget it. Once all this is done, everybody sits back. Once the ABG has been sent and it's come back, everybody sits back, and then they discuss what is the anticipated major post-operative course. So we have classified them into 3 different categories. One is when there's no major concerns, they go ahead and go for early extubation without any opiate infusion, because most of them have a caudal anesthesia given in theaters. Most of the people follow the second pathway, which is some concerns, that is review for extubation in 6 to 12 hours. A fentanyl infusion is started until extubation, and we do blood gases 2 to 6 hourly, depending on which stage we are in. Then there is the third group of patients who have major concerns. In them also, I would say there are 2 different groups, divided into 2 different groups. One who can be reviewed for extubation the next morning or by next 24 hours, which we know they need ventilation, and they need some opiates, and they need blood gas monitoring. But there are a few of them who are extremely sick, who might have come chest open, who might be on ECMO standby, or need chest to be opened, or are bleeding profusely. So those are the ones which are the most sickest, and that is flagged off very much very early on in the course of the postoperative period, so that the handover goes on to the night staff that this patient is ready for extubation, or this patient is extremely sick and you should watch out for him. So a good transfer from OR, stable handover, a clean handover, clean documentation, which is overseen by the anesthetists and surgeons, and a combined plan after a good checklist of all the things, including prescription has been done, decreases morbidity in these subset of patients. They couldn't show that it decreases mortality though. Once you're in intensive care, obviously almost 100% of our children get ventilated. So it's very important for all the juniors to learn this curve. It is the cardiopulmonary interaction. If you ventilate too hard, then you collapse the alveolar vessels and increase the PVR, and you shift the curve away from the FRC. So you want to actually ventilate where the FRC is, the functional residual capacity. And if you hypoventilate, then your FRC falls, and you can incite hypoxemia. So cardiopulmonary interactions are very important because in cardiac ICU, we say we ventilate the heart. We don't ventilate the lungs, but we ventilate the heart, because if you ventilate well, the heart will be happy, and in turn, the heart and the lung are connected, so the lung is also happy. So we should make sure appropriate tidal volumes not cause barotrauma or volute trauma. Peep effect should be kept in mind because the RV doesn't like PEEP. So there are conditions like postoperative Glens, postoperative Fontons, even postoperative ICR after their low cardiac output has settled. We want to take them out of the ventilator so the RV afterload gets better and the RV functions well in case of tetralogies. And in case of Glen and Fonton, that's because the CUP actually drives the flow. So it's very important to take out IPPV and PEEP effect from the patient. Also, you should remember the effect of FiO2. FiO2 is a very good pulmonary vasodilator, but at the same time, it can't be given in high concentration, especially in neonates. And also, you should remember pulmonary toxicity. And in some univentricular hearts, many univentricular hearts where you have a shunt, you have a PA band, FiO2 is actually titrated to balance the QP and QS. That's the pulmonary blood flow and the systemic blood flow. So effect of FiO2 should be kept in mind as a cardiopulmonary interaction. So monitoring in PCICU is divided into two. The left one, the left ones are all non-invasive, pulse oximetry, end-tidal CO2. So pulse oximetry and end-tidal CO2 are two of the most important things if I did not have ABG. In a very third world country like say Africa, when I used to do my charity trips, I used to totally depend on pulse oximetry and end-tidal CO2 and do an occasional gas in once in 6 hours, because those are very good indicators of cardiac output, perfusion, the oxygen level in the body. End-tidal CO2 is also very useful in times of reintubation to confirm the placement of endotracheal tube. Blood pressure, non-invasively, very rarely we use it, I think at the end of just before the discharge of the patient. Temperature, cardiac output monitoring is rarely used because we do not use it that much in children. Depth of anesthesia, we have just started using a little bit of non-invasive near spectroscopy. So invasive, we all know arterial blood pressure is very important. Central venous pressures are important. Some children, especially the ones with Al-Kappa and who come out of a switch operation, have left atrial pressures. Pulmonary artery pressures in a few delayed AVCDs, delayed VSDs, and delayed ASO VSDs. We do use PA lines, which are inserted during operation. Cardiac output invasive monitoring is rarely used unless they are a grown-up congenital, where you can put a PA catheter, float a PA catheter and use cardiac output. What we need to know when you're working in the PCICU is there is always effects of CPB, cardiopulmonary bypass. There is elicitation of a SIRS response. There is a fine balance with the pro and the anti-inflammatory cascade, and usually they incite a SIRS response, which is usually seen as decreasing SVR, difference in the temperature in the toe and the core. They also cause dysfunction of the coagulation cascade, which I will talk to you later, and also low cardiac output, which I will talk to you later about. Coming to coagulopathy, why does coagulopathy happen post-cardiac surgery? It's because of dilution of blood clotting factors, activation of clotting cascade due to contact to plastics used in CPB, platelet consumption and dysfunction, partly due to the CPB, partly due to the disease itself, hypothermia because they cool the patients, and when they come to ICU, they do not rewarm properly and they remain cold, and that causes denatures of proteins and coagulopathy. It also affects the fibrinolytic system, causes fibrinolysis. In very severe cases, when you have combined with DIC and hypothermia, they combined with bleeding and hypothermia, they could cause DIC. Now, all of you know that heparin is used as the anticoagulation of choice in CPB. So there is a lot of tendency for rebound heparinization or inadequate reversal of heparin, and that can cause coagulopathy and bleeding. So that should be kept in mind very early on in the post-op. The easiest thing to do is do an ACT, activated clotting time, and correct the activated clotting time to less than 140 and preferably less than 120 seconds using protamine. So what are the coagulation tests can you do when you're in PCICU? The common ones are CBC, platelets, INR, APTT and APTT ratio, fibrinogen, and very rarely we also do thromboelastography, which is called TEG. So just to give you a small picture on what we like to keep it like, and if your platelets are lower than 1 lakh, we would give 10 to 15 ml per kilo of platelets, and if your INR is more than 1.8 or 2, we give fresh frozen plasma. And if your fibrinogen is low, sometimes if they're bleeding, if they're less than 2 grams itself, we give cryoprecipitate, or if it's less than 1 gram, definitely we'll give some 5 to 10 ml of per kg of cryoprecipitate. You can use protamine if your ACT is high and your APTTs are high and you think it's because of heparin. And if your APTT and PT are both equally prolonged, your ACT is also high, you've already given protamine and the patient's still bleeding, then you can give fresh frozen plasma, 10 to 15 ml per kilo. When all this is happening, your hemoglobin also goes down. And if the patient is bleeding profusely, we sometimes target a lower hemoglobin because it's not always possible to keep 12 to 14. But usually in acyanotics, we try to keep it about 10. And in cyanotics, we try to keep it about 12. Sometimes in a very bad acyanotic, even up to 14, 15. So coming to the third point, I said CPB causes is low cardiac output, and the worst spectrum of that is called low cardiac output syndrome. It is characterized by poor perfusion and hemodynamic instability, high inotropes or increasing inotropes, oliguria with or without hyperkalemia, hyperlactemia with or without metabolic acidosis, and declining SCVO2. SCVO2 is the ABG blood gas taken from the center line, which is ideally should be placed in the right IJV, and the tip ideally should be well into the right atrium. So why is low cardiac output caused? It's caused because of low preload. If there is a low CVP, you can use some volume, aliquots of volume fluid challenges to increase the CVP and improve the low cardiac output. If there is impaired myocardial contractility, RV or LV or both, because RV and LV, as you know, is very interdependent. They are like brother and sisters. If one person is husband and wife, I would say, if one of them is not happy, then the other one is not doing well. Impaired ventricular relaxation or filling diastolic dysfunction, the common example for this is a post-tetralogy repair, the RV diastolic dysfunction. High afterload, maybe high SVR in a case of coarctation, in a case of sometimes in a switch. We try to bring down the SVR and to improve the low cardiac output, and high PVR in cases of patients with severe pulmonary hypertension, starting from advanced cases of ASD, VSD, AVCD, ASO, VSD, and the other spectrums of severe pulmonary hypertension like neonatal truncus, etc., etc. Rhythm disturbances, the most important I'm going to talk about is congenital heart, complete heart block, and junction ectopic tachycardia. Cardiac tamponade is also a cause of low cardiac output. It can be treated very easily if it's diagnosed quickly. Residual anatomic defect post-surgical repair, that's where your role as a pediatric cardiologist come in, where after the operation, it is very important to get good windows through the incision done by the surgeons, and make sure that there is no residual lesions, because if there is, they need to go into theater as soon as possible. Otherwise, by midnight, the low cardiac output will be very difficult for the ICU boys to manage. So going back to that, impaired myocardial contractility, you can use inotropy like adrenaline, which is, as you know, is a beta agonist at low doses and alpha in higher doses. Dobutamine also has some vasodilatory effect. The most common one we use is adrenaline, dobutamine when coming off. We do use noradrenaline or vasopressin depending on case-to-case basis. Milrinone is a little bit of a slow. We started much later, and levosimendan is getting extremely popular in our Bangalore unit, and we use it very, very regularly now, and we even repeat it once in 7 days. So these are the inotropy, vasodilators, pressors, chronotropy, lusotropic supports you should know about. Other than this, there is sodium nitroprusside. Rarely we use GTN. These are also some vasoactive drugs which can help in low cardiac output. Next thing I'm going to focus on is, as you can see, is increased PAP, is severe pulmonary hypertension. This is what happens. The pulmonary artery pressures goes up due to stimulus, fever, or any other inciting event. And then when the PAP goes up, the RV dysfunction that is seen as an increased CVP. And if there is an ASD there, it shunts right to left momentarily, and there will be desaturation. On top of that, the pump fails. When the RV fails, it balloons out, pushes the LV, and then the LV can't tolerate, it distance, pushes out, and then the blood pressure comes down. This is the sequence of pulmonary hypertension leading to a PA crisis, and that can cause low cardiac output. So to treat this, we have to improve the RV function by giving the appropriate ionodilators and inotropy support. Milrinone, a combination of dobutamine, adrenaline, a combination of milrinone, adrenaline does well. On top of that, you have to use your drugs to keep the baby still by sedating and paralyzing, especially during the ETT suction. Use oxygen as a pulmonary vasodilator, especially during a suction event. Avoid increased demand like fever, pain, etc. Sudden waking up by putting him on a continuous infusion of a paralysis and a continuous infusion of an opiate. Use inhaled nitric oxide to bring down the PVR. And on top of that, we've been having a lot of advanced pulmonary hypertension inoperable cases, which we have successfully used sildenafil IV sometimes oral, bosentan orally, and all the way up to even there are times when we are so stuck that on top of nitric oxide and all these drugs, we'll have to use phenoxybenzamine. So this is a machine showing nitric oxide. You can see the NO is 23. NO2, that is the impurity, is 0. We place it like this. This gets connected to the circuit. As you can see, this is a child who's on a neck cannulation, neonatal infracardiac TAPC, who's on neck ECMO, waiting for his lung to recover after his operation. So renal impairment is also caused by low cardiac output. It's something that we see. Creatinine rise is actually very slow. It's very difficult to wait for the creatinine to tell us that kidneys are impaired. So you have to be aware of the plasma creatinine is based on muscle mass. Some small children, even 0.4 creatinine is elevated, while some adults, even 1 creatinine is still not elevated. So you have to be careful of that, and you should be cautioned with drug dosing. Calculate the EGFR every day and change the drug dosing for antibiotics. Make sure there are no nephrotoxics during this period of low cardiac output, because it can affect your kidney. What do? You can initially in low cardiac output, renal impairment following low cardiac output, you can give some fluid challenge or increase the inotropy. What you're actually doing is increase, according to Frank Starling curve, you're increasing the preload, and by increasing the inotropy, you're actually increasing the cardiac output, and you're preventing the kidneys to fail. Once you know you have achieved the maximum, we could use loop diuretics. What it does is it can diurese and bring down the pressures in the venous side, and hence decreasing the renal failure incidence. Or you can go ahead and put a peritoneal dialysis catheter in the abdomen, which is usually done for us now by our surgeons because they're very good at it. So the indications for peritoneal dialysis are oligoanuria, uncontrolled hyperkalemia, worsening metabolic acidosis, fluid overload with cardiopulmonary compromise, and a rising urea and creatinine. To be honest, we do not wait for hyperkalemia. We do not wait for anuria. We do not wait for fluid overload. There are some cases of with experience, we know that they will not go out without a PD catheter. And a PD catheter will be inserted earlier in the day rather than middle of the night, so that the senior can put it in. So we use PD quite efficiently and quite commonly. So the more you use it, the more you get comfortable with it. One point I want to make to the juniors is that we do not give 100% feeds or maintenance post bypass. We come down to 50% of normal maintenance on day 1, and from day 2, depending on how they are, whether they're extubated and doing well, or if not, if they are not extubated, then we'll sometimes even restrict 50% to 70% for few days, and then only slowly, gradually go up based on the X-ray, the way the baby looks, and how much diuresis we are able to achieve. Show you that a daily caloric intake for a child is much higher, for an infant is much higher than the other age group. Then coming to other causes, rhythm disturbances for low cardiac output. So the most common one we always like to discuss is complete heart block and jet. Complete heart block is seen mostly in cases where the surgeon goes very close to the bundle. I would say VSD, intracardiac repair for tetralogy and AVCDs, and sometimes even in some other types of DORVs and ASO. So to actually, these both are AV dyssynchrony. So we have to differentiate it very well. Sometimes you get confused. So if your atrial contraction is more than ventricle, it is, and you cannot AI pace for sure, then it is complete heart block. We'll need to continue DDD pacing, that's dual chamber pacing through a temporary pacing wire, and continue supports for longer time, and hope and wait, and hope that the low cardiac output settles and the heart gets happier and the heart block reverts, or else we'll have to counsel parents for permanent pacemaker. In a case of jet, it's mostly seen post tetralogy repair, post AVCD repair, and rarely due to other repairs. Usually surface cooling to get them to mild hypothermia, correct the electrolytes like potassium and magnesium, slow down the heart rate by cooling, and then override pace them, decrease the adrenergic drugs, unnecessarily drugs which are going and inciting adrenergic response, correct the lactic acidosis, open the chest if you want, optimize anything you can do to optimize the cardiac output, and then they usually settle down. And very rarely, if that is non-controllable, you try to cardiovert them pharmacologically, and or at least bring down the heart rate lower to about 130, 140, so that you can overdrive pace by using amiodarone. So this is just a quick one. You're all cardiologists. This is cardiac tamponade. So this is mostly a picture of a medical cardiac tamponade. You should remember in surgical tamponade, a small regional tamponade, say in and around the right atrium or behind the left atrium. Even that small clot can cause tamponade in a failing low cardiac output heart. So we should be very, very vigilant, check for all views behind the heart, in front of the heart, and also look for any variation in respiration to the gradients across the valves. When all else fails, you take a nap. Not actually, you don't take a nap. You think about ECMO, Ecmo, extracorporeal membrane oxygen. We are one of the largest centers doing pediatric cardiac ECMO, and we have seen that when you anticipate a cardiac arrest and initiate ECMO when they are in low cardiac output, they actually behave well, and we can get them out more successfully. We almost have a 40 to 50% success rate across all spectrum. Some have even 70%. Some have bad prognosis. So it accumulate overall comes to about 50%. Special consideration we need to know about neonates. They are all immunocompromised, might have a certain neonatal sepsis. They have a rate-dependent cardiac output. They have a high chance of intracranial bleed. They have hypothermia, or they get into hypothermia very fast, so they need to be in a warmer bed. They can get hypothermic very quickly because of SIRS, because of sepsis, or because of the bypass. They have high instance for necrotizing enterocolitis. The picture you saw earlier was a 5-day-old in obstructed TAPUC with severe sepsis who had a whiteout lung. We put him on a preoperative ECMO through the neck, decongested his lung. A day later, we did the infracardiac TAPUC repair, and post-operatively, he was chest open for a couple of days on nitric, and the chest is closed now. He is slowly beginning to open his eyes on a ECMO from the neck. The chest is closed on nitric. So we are hoping that we can get him out of the ECMO and then take him out of nitric and then extubate him. So these are the uses of, so ECMO is used widely now, not only post-operatively, now also pre-operatively to improve outcomes. Coming to neonates, they have a high incidence of intraventricular hemorrhage. You can do a cranial ultrasound and grade them from 1 to 4. Up to 1 to 2 is acceptable, but 3 and 4 are not very good prognosis, especially if you see preoperatively. Consider not going ahead. This is called HFNC. This is a child on HFNC on oral tube feeding, very comfortable. We have been using this a lot. What we do is we give about 1 to 2 ml per kilo of flows and keep them on not more than 60% oxygen so that they can calmly sit down. They get about a PEEP of about 3 in their nasopharynx. This obtains any problems regarding pulmonary hypertension, hypoxia. This is a way to give nasal CPAP or BiPAP. Very good. Also, technology helps them keep them quiet, keep the PA pressures down, keep the oxygenation level good, CO2 in control, and then so it gives the children time, especially the smaller ones, to keep calm. And also the requirement of sedation is much lesser when they are oxygenated well, when their upper airway is open. Their requirement of sedation is much lesser. So going to univentricular heart, I want to quickly show you this. So if there's too much blood flow and pulmonary hypertension, they do a band. They say in the neonatal period, but mostly in our part of the world, they come at 6 months, sometimes even at 8-9 months. And then when there's a balanced blood flow, then you do a Glenn, and then you do a Fontan. When there's too little blood flow, you do a BT shunt, and then do a Glenn, and then do a Fontan. So univentricular hearts are different. When you have too much blood flowing, you need to restrict the blood flow by doing a band, plus on top of that, doing ventilation. You use ventilation to restrict the blood flow, like use less oxygen, don't hypoventilate them a little bit, play around with their pulmonary vascular resistance so that the QPQS balances out. Whereas even in a BT shunt, depending on the shunt, most of the times they overflow. So you have to post-operatively try to control that using ventilator, and you can correct the hemoglobin, you can use saturation, I mean, you can use FiO2, you can use Peep to play around with their QPQS. Now, coming to late complications, there is chylothorax, mostly commonly seen due to high pressures inside the heart rather than injury to the thoracic duct. So mostly it's managed conservatively by using vasodilatory, ionodilatory drugs like Melrinon, giving them a fat-free diet, keeping them NPO for some time, using octreotide, and then within a week or two, usually they subside. Paralysis of the hemidiaphragm, unless if they are infants, they need to be fixed, they need application so that they don't have incidences of aspiration when they go home. Brain injury can just range from a simple seizure to any bleeding, which can be catastrophic. So discharge criteria is usually taken jointly with the senior cardiac surgeon and the intensivist. Minimal oxygen, hemodynamically stable with CHOOSE is congenital heart early warning score, which we have devised for both acyanotics and cyanotics. Appropriate saturation and respiratory rate for the lesion corrected. We have to be off all inotropes, off the tubes and plastics. A child should be active, alert, and oriented. Feeding should be done orally in most cases, in almost all cases. And the caregiver should be comfortable, after all, to handle the child. There are some mobile apps for my juniors who can download a pediatric cardiac guide from one of my colleagues called Mike Anders, and also Pcicu guide from RCH, Royal Hospital of Melbourne. So that's the end of my talk. Just to summarize, I was just going through the effective handover from OR to ICU. I was going through the why there is low cardiac output, effects of bypass, and how you can manage arrhythmia, most common arrhythmias, how you can restrict intake in early post-op. I spoke about peritoneal dialysis a little bit. I spoke about some early and late complications, pulmonary hypertension, and gave you some scenarios so that you can take home a little bit and then read up on that. It's a vast topic. That's why I've not touched on pediatric surgical ICU. I just want to keep it on cardiac. Thank you very much. I'm happy to take questions. Thank you.
Thank you, sir, for a nice and informative class, sir. Now the session is open for all. Is there any question or query?
There are some questions from Ashfaq. You just read them for Dr. Ryan.
In the chat box.
For Ashfaq, you can ask directly.
Okay, thank you, Dr. Shetty. A few queries from my side. Please give some insight about the APRV bilevel and high frequency ventilation, indication, initial setting, and waning. This is the first question, and I think the second.
I'll take that question. Yeah, let me take it one by one. So normally, ideally, patients should be on post-operatively on pressure control ventilation. But since in pressure control ventilation, what happens is you give a certain pressure, and when the compliance of the lung changes, especially in a pulmonary hypertension lung, when the compliance changes, suddenly they hypoventilate. Now, our nurses do not listen to alarms, even though we put them on. So we have a real terrible problem. So we are mostly into a pressure controlled, volume guaranteed kind of settings in our unit, which goes well with us. Your question is, when do you use APRV? To be frank, I've used APRV once or twice in a year, and we do not use it regularly, for being that most of us are not trained, or we don't know how to use it, or even if I know to use it, I used to use it a lot in UK. And when I came here, once at 8 o'clock or 9 o'clock, when I go home, there's nobody to troubleshoot it overnight. And that's dangerous. So I rather put them on our normal PCVG and go on a high rate. Same comes with high frequency oscillation ventilation. We use it only just before Ecmo in an ARDS lung, something like that. And again, that has not been very popular in our center, just because we are not neonatal ICU trained. We have not used it much in our training period. So we generally keep it simple, and so that everybody can use it and play around with it. So that's the answer for that question. The next question I see is ventilation strategy for wet lung and pH situation. Is that right?
Yeah.
Okay. So as I showed you the diagram, you need to ventilate the baby at an optimum PEEP. When you give an optimum PEEP, you will not be inciting further pulmonary hypertension, but there will be adequate oxygenation. So wet lung in a situation like example in a TAPVC could be because the LA hypertension is high because the LV is small. So then you should need to be on good ionodilators like milrinone. Keep your pressure low. Wet lung in a TAPVC could also be due to overfeeding or over maintenance. You're giving high amount of maintenance. You need to restrict that. On top of that, you need to be on quite a high dose of Lasix so that the water comes out, and you're always negative 100, 200 every day. And on top of that, you need to make sure that your ventilation strategy, that is, the strategy is to just not cause too much, not give too much PEEP, also not give too little, get the optimum oxygenation. When all this come together, you should be able to do an effective extubation. And if you have gone above 3 to 4 days, we don't even ask now. We always go at least on HFNC, high frequency nasal canal oxygen, because that is connected to the patient. It doesn't cause sudden hypoxia. Patients actually like it. Babies actually calm down because it opens up the upper airway. And we have seen that the RS post our HFNC experience is almost nil. And also it gives you a time to assess to re-intubate also. So also we also use it to pre-oxygenate before re-intubation. So this should be a strategy, everything, optimum PEEP, vasodilators, good pulmonary vasodilator drugs, optimum oxygenation, and coming out of the ventilator at the right time with the right sedation. And did you say KO pulmonary shunt? Is that Glenn?
Yes.
Yeah, okay.
Yes.
So ventilation strategy is very simple. You just give a little bit of PEEP and continue ventilation as soon as they're not bleeding. Usually the Glens will be a redo, and the Fontons are definitely redos. So when they're not bleeding, you should try, if your cardiac output has been achieved, you're not too hypoxic, then you should try and get them out of the ventilator as soon as possible, because that itself improves the cardiovascular status. Yeah, go on. What's that?
Okay, another more question, I think.
How you detect barotrauma and volutrauma or ALI? See, traditionally in a cardiac ICU, they have been ventilating with high tidal volumes up to 10 per kilo. That's because we are mostly a surgically led. And slowly, when people like me who get trained in intensive care, we have actually brought it down to about 8, and sometimes even we do 6 to 8. But what is most important to know is that it doesn't matter sometimes. The lungs are quite good. They're not an ARDS lung. And a little bit of this barotrauma, volutrauma, and ALI is a little bit of too much of, over exaggeration in a pediatric cardiac world, not in a pediatric medical world where you have ARDS, but in a pediatric cardiac world. Up to 8 ml per kilo, 6 to 8 ml per kilo should be okay. And you should not be worried about volutrauma, barotrauma, or ALI. And if you have ALI, volutrauma, barotrauma, you should think of other causes like sepsis, aspiration, or any other sepsis from other side, or a SIRS response to some blood product. That's what you should look at. Yeah, Mohammad Musafil Hussain asks when you consider ECMO is indicated. Okay. So post-cardiac ECMO, it's very simple. There are 3 indications. We have very simplified it very well. Failure to wean off CPB is the first indication. Okay. If you're smart, you can predict a cardiac arrest. And so before that, when the patient is in low cardiac output, electively, you can go on ECMO. And the last is eCPR, ECMO CPR. When the heart has stopped suddenly in the ICU, you're doing CPR, you've tried for 10-15 minutes, heart is not coming back. It could be a shunt block, it could be a overperfusion of the shunt and a myocardial ischemia, or you know that there is a residual lesion, the VSD has come out and you're not had time to go in, or he has arrested because of a reversible cause, or you don't know the cause and you think you can find out the cause later on. Maybe it's hyperkalemia. It could be anything. So those are the indications where you would do good timed ECMO or even good CPR ECMO. Have I answered that question, Mohammed Mufasul?
Yes, sir. Thank you, sir.
Okay.
Sir, now I request Professor Salam sir and Professor Shajil Banerjee sir to say few words regarding this class.
Thank you very much, Dr. Jannat, for your nice moderation, and thank you, Dr. Riyan Shetty, wonderful talks delivery. Really, I enjoyed, and very short and brief and concise, so that we could understand the situation in ICU in summary. But I have a query, not a question actually. L-arginine is an essential amino acid. During the hypertensive crisis in postoperative ICU patient, particularly in shunt anomaly, the amount of L-arginine infusion influx into the cell during the cardiopulmonary bypass is reduced. So there was some attempt or study L-arginine infusion preoperative and peroperative to prevent this pulmonary hypertensive crisis, and this was going on. This kind of patient do not usually develop pulmonary hypertensive crisis, and these are the study attempts in those countries actually where the nitric oxide inhalation was not available. So would you like to comment on this? And the second is, when you level a patient a pulmonary hypertensive crisis in postoperative situation.
Okay, okay, doctor. I'm extremely sorry. I have not seen that study. It would be great if there was such a easy fix to. Can I continue?
Amino acid, it is available in the market, and you can infuse it, and you can have a study on it, particularly for the developing countries where the nitric oxide inhalation is not available.
Dr. Abdul Salam, with due respects, I have not heard about the study. I would be very surprised if it was that easy to reverse pulmonary hypertension, which has been going on for 6 months or 10 months. Imagine an example in an AVCD, just by giving an infusion. So I would strongly recommend that centers like yours actually go ahead and start using nitric oxide, start talking to the industrial oxygen people who can produce nitric oxide from liquid oxygen. The byproduct of liquid oxygen is nitric oxide, and put them in cylinders and give it to you. Start using it, because we have about 7 machines now for like a 70-bedded ICU. And sometimes there's a question how long you use. There's a child who's on nitric oxide for 15 days now after a 1.5-year-old AVCD repair, which is inoperable actually, but they do come out. They do come out after a long time. We come out and quickly put a tracheostomy, take all the inciting events out. They do go home. We had a TAPUC with a big VSD which needed to be devised post-operatively. We use nitric oxide. They keep trying to arrest on us. It is extremely impossible, like, to do anything with that kind of pulmonary pressures, to do anything without nitric oxide. I will look into it, but I firmly feel for all the juniors is that nitric oxide is something what will change the management, how you do cases who have pulmonary hypertension in the ICU. I can see somebody who asked, do you use 20 ppm or 23? We use 20 ppm. You saw a photo of 23. That's just because we couldn't dial it down to 20. And there is somebody how long you use. Ideally, you should not be using nitric oxide for 3 to 5 days. But when a child has got very high PA pressures, like the one I explained to you, and they're trying to die on us, there is no other way but to use nitric oxide. That's the only thing that keeps them going for days to days until they change their characteristics and come back to normal, so that we can bring them back to go towards extubation. What was your second question, Dr. Salam?
Actually, in ICU setup, when you at hot level, at hot status, you level is a pulmonary hypertensive crisis.
Okay. So, Dr. Salam, we have gone away from waiting for pulmonary hypertension to happen in ICU and predicting pulmonary hypertension. So it's gone to a stage where if there is say a 1-year-old ASO VSD or a Tausig Bing, people won't even ask whether you want to start nitric oxide to me. It will be ready when when the patient comes. So whether it's switched on or not is a different question. After that, the rounds they will tell. Or sometimes we get a phone call from the ICU OR itself, and sometimes the surgeon comes, sees whether there's nitric oxide, and then goes and calls for the case. To the extent, so I think in our setup, more and more we have started predicting pulmonary hypertension. We have been preventive in causing pulmonary hypertension. Our outcomes are better. Once you have had a PA crisis, that's the question you asked. Once your registrar says, sir, I had to take the baby on handbagging, I bagged him or her, then the baby's CO2 in the monitor came down to 20, and I gave 100% oxygen, and then the CEP which had gone up, and the blood pressure which had gone on, after a bolus of adrenaline, a small bolus of adrenaline, the BP came up, and because of the bagging only I could save him. You know that this baby has gone into a PA crisis. So that will be a real definition of a PA crisis. But what I, as an intensivist, I'm trained to do is to prevent these events so that they don't come. These events mostly come when the baby suddenly wakes up just before extubation, when they're sleeping at the middle of the night without adequate sedation, or without bagging very well, without oxygenating very well, or suctioning for too long, switching off the ventilator after connecting back to the ventilator. These are the times when pulmonary hypertension happens.
Yeah, thank you very much.
Thank you, sir.
Cases you start with sildenafil and bosentan or phenoxybenzamin, or you straight go for nitric oxide as it is available?
There are some borderline cases we use IV sildenafil because that helps us to extubate them earlier. Because once you put them on nitric oxide, you're at least 3 days down. You have to extubate. You can't extubate before that. So there are cases, the borderline ones, but there are some inoperable, like more than 6, 7, 8-year-olds, AVCDs, EAPVCs, which are obstructed in the neonatal period. It's very difficult. It's very difficult for me to believe there are centers who say that, oh, we have got very good outcome, but we don't have nitric oxide. So it's very difficult for me to understand how they do it. At least in the developing country with sepsis lurking around very close by, it's extremely difficult to believe.
Thank you, Dr. Shetty.
Thank you. What is the upper limit of CP you accept in ICR before increasing inotropes, and how you give preload in ICR? Good question, actually, Ashfaq. When I left Great Ormond Street, they told me that in an ICR you should give volume, and keep the CEP high. Those ICRs are all 6 months, 8 months, 9 months. From my heart, I'll tell you that our ICRs, especially the ones who come from the Bengal region, are much more difficult than the ones we used to do in London. So what is the upper limit of CEP? When the CEP hits about 12 to 14, everybody gets a little worried. That's when they stop giving volume and they start giving increasing the inotropes. And more, we do not increase the inotropes until the blood pressure comes down. If the CP is high, you just wait, don't give any volume. and wait for the blood pressure to come down, then only increase it, because increasing the inotropes also is detrimental. So it's a very cat and mouse game. So it's very difficult to explain to you unless you work with us. And once you work with us for a year, then you'll understand when are we worried, when are we just walking away from the bed space and saying it will be all right.
Thank you, sir. Sir, one question left in the chat box, sir. How much expensive in using ECMO and nitric oxide plant?
Okay, so we use ECMO. We use the Mackay Rotaflow, and we get one oxygenator. I think your surgeons will know about it, from a Sorin company, who also give us the bypass machine. That's called a Didico. It's extremely cheap. It comes to about 10 to 15,000 or 30,000 for us. So the whole circuit will cost about 50,000 rupees. So that's the only way we can be affording to do ECMO, because if you really put a proper circuit, it costs way beyond that, like 2.5 lakhs. So that's one thing about ECMO. And the NO is a machine. So the machine is expensive. The ones which we use, the one you saw on the picture, is about 10 to 12 lakhs. It's done by GE. The unfortunate part of it is it's very difficult to titrate the NO in that. But the newer machines, which come for about 20 lakhs, actually you can dial in the number and click it, and you can even bag with nitric, which we don't have yet. We might buy one very soon. So the other cost of the NO machine is the cylinders. I believe our cylinders are about 5,000-10,000 rupees per cylinder. It comes to about 2.5-3 days, 2 days at least. So yeah, it is expensive. It is expensive. But if you calculate the number of days the patients can stay and the morbidity and mortality, it comes down immensely. It comes down immensely. And actually, we should not be offering a high-risk congenital heart surgery if we don't have ECMO and NO. When I say high risk, we are talking about neonatal surgeries, TAPVCs, truncus, switches, adult, bigger kids with VSD, Eisenmengering, even AVCDs, bigger kids with AVCDs. We should not be offering them surgeries if we do not have these two things, because it's not fair, because you don't know who will require, who will not require. There are instances when patient has had high PA pressures, pulmonary hypertension crisis for days together. Intensivists have not used nitric oxide, and they have gone home with sildenafil bosentan. But it's not like you can guarantee that if it's your own child.
Thank you, sir, for your valuable answering. So now I request Brigadier General Nurnar Fatima Madam to say a few words before conclude the session.
Thank you, Dr. Jannat, for your nice moderation. I would like to express my heartfelt thanks to Dr. Ryan for his excellent and outstanding presentation. Actually, what I feel always is that either medicine or surgery, whatever the subject is, it is the blending of a science and art. So what are the things you are blending? So Dr. Ryan, you were mentioning that per year you are doing 2,500 surgeries, and every day, and you have 70 beds. So you are working so much that you have innovated, or you are used with your own arts now. So patients are coming with you with lot of signs, like with bleeding, with like low volume, low cardiac output state, with arrhythmias, with many other problems. So these are the sciences. And with your experience, you are dealing with these signs, and that is the blending of your thinking. So that is the artistic part from a doctor. So whatever I have noticed in your presentation was that you have blended the science with your arts so nicely that at the end of the day, the outcome of your treatment has become excellent. So this is the thing what I have noticed from you in this presentation. And actually in our country, what is our problem? We have now many surgeons working, but the thing is that we have no nitric oxide yet. So how could they actually take a patient for whom nitric oxide is mandatory in the post-operative period? Even we have ECMO machine in some of our hospitals, but there is no actually pediatric circuit. Only for the adult patient in some of the hospitals we are doing, but you may know that for some of our neonatal patients like persistent fetal circulation, persistent pulmonary hypertension, we need ECMO, but because of the lack of availability of the circuit, we are failing to do that. So some of our persistent fetal circulation, they may die. Another thing is that you are working in the surgical ICU with the post-operative patient, which is very different from the medical ICU where we work with the other kind of patient. And I think this is the reason for which neonatologist or pediatric pulmonologist, they are not working in the surgical ICU, because this is completely a different scenario. When you work with the neonate, you have the chance of development of intraventricular hemorrhage, necrotizing enterocolitis. You need to actually concentrate on fluid and electrolyte balance and others, especially on the neonate, because their body surface area is very less and their amount of total body fluid is also very less. But even then, we don't see any neonatologist working in the surgical ICU. And we are very happy that the surgical intensivist and the intensivists like you people, you are managing these neonates so nicely and without any help of the neonatologist. So everything we have discussed were very nice, and we have learned a lot from your lecture. Thank you very much for this excellent presentation, and we are looking forward for your other presentations, which you will deliver in next few classes. And again, I would like to thank from my side and from our Bangladesh side for this excellent presentation. Thank you, Dr. Ryan.
Thank you, doctor.
Thank you, madam.
Can I say
speech.
one word? Can I say one sentence?
Yes.
So my humble request to everyone in the panel and Professor Fatima is that you have cardiologists, you have cardiac surgeons, you have cardiac anesthetists, and you have some intensive care doctors also. But what I have realized, pediatric cardiac intensive care is a separate specialty. The day we realize that, and people get supported to get trained only in that, and are taken back into the system, and you need about 2 or 3 of them who can then bring through them, we can get all of the cardiologists to talk to the cardiac surgeons, to talk to the anesthetists, all of them talk together. Along with them, they talk to the physios, respiratory therapists, and the infection control, and the nurses. The most important person in this whole equation is the nurses. And what we have done in Bangalore is that the intensives have kept the nurses together. We keep teaching them, we keep training them, keep talking. They keep leaving us, but we keep teaching them again. We don't give up. So somewhere it just keeps going, and then we can achieve. Last year we did 1,200 cases, and our mortality rate was 1.8%. That is phenomenally low for the types of cases we get from all parts of the country and abroad. So I think the most important thing is to get people who can work in a multidisciplinary team and have intensive care as the headquarters for all activities, be it cardiology, post-cardiology care, or post-cardiac surgery care. And then your outcomes, then the cardiologist and cardiac surgeon can do whatever they want, and you can still bring the patients out. That's my parting message to everybody in the panel. Thank you so much, and please stay safe.
Thank you, sir. Thank you, madam. Now we are at the end of this session. Thank you, everybody, for attending this important class.
Give announcement for the next class, please.
Our next class will on the 28th May on stenting on congenital heart disease. Faculty of the day will Dr. Shiva Kumar.
Yes, Dr. Shiva Kumar from Madras Medical Mission.
Yes, madam.
Okay, you can conclude.
We are now on the end of this session. Thank you, everybody. And Assalamu alaikum and very good afternoon.